Welcome to the Sense of Hope podcast by One Life. I'm your host, Helen Gibbs, and today we are speaking to Helen Gibbs. Helen qualified as a New Zealand registered dietitian in 1998 and has worked most of her career in primary and community services in the UK and Aotearoa, New Zealand. Over the past 3 decades, Helen has dedicated herself to refining her skills through research, experience, and ongoing training. In 2020, she completed her qualifications as a dietitian prescriber and now supervises other dietitian prescribers. Helen has a particular interest in the prevention and management of metabolic disease. However, recognising that many people have traumatic experiences around food during their formative years, she has now developed a whole person approach to nutrition. This whole person approach has now evolved into a whanau-centred approach. Welcome to the Sense of Hope podcast, Helen.
Kia ora, tēnā koe, tēnā koutou katoa. It's lovely to be here. I'm really excited to be talking about this. Set me going. I'll talk about dietetics and the things I do as much as possible.
Fantastic. It's going to be an easy podcast for me then. That's fantastic. Yeah. The first question I have is, what got you into dietetics? What made you want to be a dietitian?
So I actually whakapapa dietetics. I have 2 aunties and a mother who trained as a dietitian. And before we came on air, we were talking about, at school you got offered teacher or nursing. So her mother was looking at those options, and her mother was very committed to her daughters having education through the experience of having to be dependent on her own parents during the Second World War when her husband went missing. So she was determined that her daughters would have an independent career. So nursing meant that they might see men's bits that they were not married to, and teaching meant that they might have to deal with horrible nitty children. So in fact, dietetics was the answer.
Oh my goodness, that is a funny story. Okay, we don't want to see men bits we're not supposed to see.
Yeah,
there's a story about that from my first years of nursing, but we'll leave that for another time for sure. So you became a dietitian, and that was a few years ago now.
I took a bit of a scenic route to get to dietetics because the first time I applied I didn't get in, which was probably actually for the best, though it was really hard at the time. So at that point we had the 4-year undergraduate. It was only just renamed from home science to consumer and applied sciences. And then there was a 15-month postgraduate dietetic training, and I assumed I'd get in first time round, and it was like, oh, heck, now what do I do? And so I ended up folding paper in a paper factory, very good lesson in why you finish your education. And then I ended up tutoring in the first year food science program while the lecturer was completing her PhD. Then went into food science, did that qualification, got my honours in food science, went off and worked in the dairy industry, decided that actually milk powder was pretty boring, and started my application for dietetics at 3 o'clock in the morning in the dairy factory. Rang, they told me, well, actually we've closed, but if you can get it in the next 8 hours, we'll accept your application. And I got them, thank God.
Well done. Obviously things have changed a lot since 1998. I'm curious to know, how has your practice changed? Because it sounds like you've really formulated quite a new model for yourself.
So I say that it's a new model, but I suspect it's been independently invented by a number of dietitians. But the broadest group of dietitians in New Zealand at the moment are the dietitians who work for Te Whatu Ora. Now, there's approximately 800 dietitians in New Zealand, of which 3/4 work in secondary care and associated. And last time we did a fingers and toes count, only 35 dietitians recognised themselves as primary care community-based dietitians.
Wow, so you're quite a rare
that
breed.
Doesn't even count the private practitioners.
Right.
And so that whole place of us being at the prevention end, yes, we have people in the Heart Foundation, things like that, but we don't actually have that many people on the front line with the GPs able to refer to us. And that's been a really, really big thing that I've always said we're in the wrong place. If there are any dietitians listening, they're probably about to shoot me because I say, actually, we should probably do very little of dietetics in hospital because, and this was from a learned experience, I was part of a clinical trial. I had things stuck in both arms as they were doing infusions and things, and then they asked me a food frequency questionnaire. And I said a very rude word. Turned out that I was actually my blood sugar was going really, really low, and I freaked the doctor out. But it was a learning lesson. There's at the moment that you've got four things going into you, and your brain is in an unsettled situation. You're not going to be able to learn about nutrition. That's the last thing you're going to learn.
Right. So you're focused very much at the primary care end.
Yeah. And the thing is that primary care is a life course thing. I see people all the way through adulthood and into end of life. That is all part of primary and community care because it's actually what I say, free range patients. They're actually coming to you because they consent to come to you, not because you've turned up at their bed in the hospital.
Right. Yeah. That I can imagine that to be the case. So can you give me an example of the typical, or is there a typical person that you might see?
This month has been a wonderfully atypical typical. So I do a fair bit of weight loss surgery with one of our the local private consultants, and just it seems that despite the cost of living crisis, there's a lot of people who are wanting to go down the weight loss surgery route, and I sometimes say it's the least bad option for some people. I get a number of GPs who send me what I call all kinds of interesting things. I have the odd self-referral. And this month, as I said, pretty atypical because I've ended up with 3 rare diseases. And so that these are often conditions where there is a nutrition element, but this person might be the only person in the South Island with this condition. And I'm not afraid of going to international guidelines and things like that. And as I read through them, I'm making notes and going, well, okay, so the things I need to emphasise are this. And
right.
Sometimes there's great guidelines. Sometimes it's like, well, this is going to be a bit of a lick and a prayer.
Yeah. I can imagine, especially if you are working with such rare cases.
So one of the cases that came up is one of the long QT syndrome ones. So basically the heart arrhythmias. And immediately when he started talking about it, I was thinking, well, something's going on here. It turned out that it actually does affect insulin levels. And actually it's probably insulin levels that are as much having an effect as the other aspects of it. And we're currently just trying to work out exactly how to manage what is a flat glucose curve.
Right. Oh my goodness. Okay. We won't get too technical.
No,
this is enough. This is enough technicality for us all. Somewhere along the way, you started to discover a little bit around the trauma side. How did that come in, and how did you fit all that together?
So with Mum being a dietitian, she was an outpatient dietitian from when I was 8 years old through till I'd have been about 12 or 13 when she went over to the Heart Foundation as a community-based dietitian. And I kind of knew what she did. And one of the things she did, and as I got older and we talked about it, was she said, there's a lot of really unhappy people out there, and often they eat their feelings down. And so this was planted in a small person's brain from a very young age. Yeah. And also Mum being the wise person that she was, looked at her quirky youngest and thought, actually, this wee person needs some skills. And she got me the book TA for Kids. And so that I had a language in which to explain what goes on in people from the age of 8 years old. And
interesting.
And the thing is that it meant that although I would have personal struggles at school and things, bullying experiences and that kind of thing, I could often see what the pattern was and see people's inherent unhappiness.
So you said TA?
Yeah, Transactional Analysis for Kids. Fantastic book.
My God, I didn't think a book existed like that. That's amazing.
The funny thing is it's still in print, and I have to import copies if I want them from the US. But every so often I go, I wish I had a little chunk of money that I could go and get 20 copies so I could actually be handing it out to people.
Yeah, so interesting, isn't it?
Yeah.
So you got that seed planted at a very young age. How long was it before you really started to bring that actively into your dietetics work?
So the training is tough. As you can imagine, square pegs and round holes find life really difficult, or as dietitians are notorious for, they eat their young.
Nurses do that too sometimes, don't you worry. It's not the only profession.
Yeah, and so I had to be very mindful and do what I saw rather than do what I necessarily understood during my training. But my first role, which another entertaining wee story, it was actually in the UK, despite being New Zealand trained. I had a very strong intuitive sense I needed team leaders who were going to be strong mentors. And my first mentor was a dietitian who had worked in the early HIV work in London, and for various reasons ended up in the far northeast of Scotland. And she gave me the freedom to start working in the way that I wanted to, as long as I completed my clinic scheduling on time. And so that was the chance to start thinking very much more holistically than what I'd been taught, even though I probably had been having those thoughts all the way through the training.
It's so interesting, isn't it? I was speaking to a psychiatrist on the podcast a couple of weeks ago, and he talked also about allowing clinicians to actually excel in those little areas that perhaps no one else is getting a really good look at. But instead of putting these cages and boundaries and, oh no, you can't possibly do that, actually allow people to actually follow those instincts and go down those routes. Can be so
helpful. And I think
helpful.
one of the things, and it is probably in our profession, and I suspect in a number of the allied health, there's this fear of opening the emotional basket and then not knowing what to do.
Yeah.
And yet I came to the perspective as if we don't acknowledge the emotions that come into the room, people are deaf to us.
Yeah.
And particularly if we do inadvertently, I hope inadvertently, re-traumatize someone by something we say or do, they are going to be doubly deaf to what we did. And that's been always on my mind, is that people who carry hurt can be deafened to what you're going to say so easily if you don't understand that actually we don't come in as blank slates, we come in with our own stuff, and we actually have to hold that in a way that we can then support the person, but also that what we are is never absent.
So how many people do you think come to you, this is a bit of a trick question, that have significant trauma as part of...
Okay, so when I was working in the public system and I used to have students, I used to say, don't be surprised. Oh no, do be surprised if we get through the clinic without tears. Because basically I would say that in the public system, I'd say 2/3 of people have significant traumas of some degree or another. It's actually kind of nice when I have people who've not got trauma. I sometimes go, oh, phew, I'm not going to have to be dealing with layer upon layer of the relationship with food. Admittedly, I'm always a bit suspicious and going, are we going to get the door open, end of third consultation disclosure of trauma?
Yeah, which can happen because I'm sure that many people do not acknowledge or do not even think that what they experienced was a trauma. They haven't even, considered that that might have contributed to the change in their behaviour or, using food as a soothing tool. So I can totally see how that would happen. And a few weeks down the track or a few consults down the track, there's, oh, hello.
And particularly I have a social worker supervisor, and the way she phrases how I work is I hold space very well for people.
Yeah.
It's a place that people can come in and actually can bring all kinds of crazy stuff and actually be safe to share it.
Yeah. As a dietitian, you're also in some ways part counsellor by accident, really.
Yeah, and one of my interesting frustrations was looking at MSD's counselling criteria. If you want to get counselling from Ministry of Social Development funding, the person who you're going to has to be a counsellor, a registered counsellor. I then looked at that and discovered that I would have to do a 3-year qualification, and it was like, no thanks. And I think that and I guess this is one of the broad themes of how I think about it. We are all made weaker by not recognising that lived experience can be a very powerful part of developing our professional skills.
Yeah, that is so true, isn't it?
Oh, yeah.
Yeah. Is there something specific that you can say around the way that your practice is a bit different?
I guess the thing is that if I had to use a phrase, I'm not afraid to speak truth to power. Whether that power is, writing a letter to a consultant, advocating for someone's care, it might be actually challenging someone's perspective that they think that the only way they can do something is. And it's one of the things that is sort of tricky about being in that space is that you actually have to have very strong clinical skills and to be able to justify your clinical decision making within quite a rigorous framework and within quite a tight scope, while also being an empathetic practitioner, being a dietitian working within clinical scope of dietetics, all of those things. So it's actually often a constant juggling act. And when I'm supervising young practitioners, I'm sort of sneaking in some of these techniques and things like that. But I also say you've got to be at the top of your game, that when the doctor comes back and says, well, I don't understand why you're saying this, say, well, at the moment, with our current thing, the HbA1c is up here. And if we're going to get it down, it's not going to be just through changing medications or just through changing diet or just doing this or just doing that. This person also needs this.
Okay, so this is where the whole person approach. And for those listeners, HbA1c is a measure of blood glucose levels over an approximate 12-week period. If we are looking at this holistic approach, I was actually speaking to a bariatric nurse last week about this. It's not simply about the food.
No, if it was just about the food, it would be easy.
Yeah. And what barriers do you face? And
so one of the single biggest barriers is people will be at their hairdressers, at the GP, their uncle will say, oh, weight loss surgery, that's a cop-out. Oh, that's the easy way out. It's not easy. And part of what makes it not easy is that lack of acceptance that if it was just as easy as eating less and being more active, no one would be doing weight loss surgery. No one would be using any of the weight loss drugs. It's not that simple. And when I'm introducing myself first to my clients, I say, when I trained, we believed it was about 80% things we could control in our lives that affected our weight, and only 20% which was in that black box underneath. I believe it is the other way around, that it's 80% things that we actually have no real clue about. Though after as many years of practicing as I do, I can get some pretty clever ideas about what might be going down. And only 20% of things within our control. And that 20% is being actually very heavily eroded by our food systems.
Talk to me about that, because that's another.
So, for example, when I have a young person coming through who's looking at weight loss surgery, one of the things I want to know is, actually, do you have any cooking skills? Or do you rely on Uber Eats? You'd be amazed how many do. Do you know what it's like to eat with a regular eating pattern? Or have you got caught up in intermittent fasting or whatever, which works for some people but won't work for other people? Actually, do you know how to go grocery shopping? sounds silly, but actually there can be a big gap in the skills, particularly. And I use a very simple way of describing this to people. I say, look, you're not failing as an adult if you don't have these skills. It is for some reason you didn't have the capacity or energy to acquire those skills, or you may not have had someone who was there to teach you. Our job is to work together and find ways of resolving gaps.
So we've got knowledge deficits, we've got poor food choices, which obviously is part of that picture. What about the impact of poverty?
Oh, I mean, one of the things that probably the biggest ethical dilemma I struggle with is knowing how many people are tapping into their KiwiSaver to have their weight loss surgery, or putting another mortgage on the house, or getting loans from family. Because the reality is we do, I think that my last count, 500 surgeries in the public system, and you have to have virtually out of control diabetes to get your weight loss surgery in New Zealand. And there is tight age cut-offs, and there are a number of other cut-offs that would make many people ineligible for it. And the thing is that these people who are coming forward for surgery, they recognise their lives are being shortened by their health, and they don't want that. And so they're prepared to put their futures on the line for it in some ways. And that's not even thinking about the people who can't even get that far because they don't have the house to mortgage. They don't have that KiwiSaver. There's a food study that's done annually from University of Otago that looks at the cost of feeding individuals in a family across New Zealand. And it's got a basic diet, an intermediate diet, and a liberal diet. There's no way that someone on a benefit would ever be able to eat a healthy diet based on this.
Wow. Okay.
So I also have a great range of letters that I write to WINS, Work and Income, for about this person hasn't used all of their disability allowance. They need to put it towards more food.
You may know that my interest is specifically, obviously, in mental health, but even more specifically about the impact of nutrition on mental health and well-being. And so, we know that an ultra-processed food diet contributes what is associated with poorer mental health, for example. The more I go on and the more people I'm meeting through these podcasts, I'm saying none of these things can be separated. The obesity, the poverty, the nutrition, the mental health issues.
And some of the acquired conditions. So I'm not saying that all autism is caused by this, but low iron levels have been evidenced as increasing the risk, maternal low iron levels, of increasing the risk of a child being born with autism. Maternal low zinc levels increases the risk of a child being born with ADHD.
And we are not looking at this in a national level, are we?
No, and I mean, I went and represented about psychogeriatric care in the community, and they're wanting to have more people with their dementias and Parkinson's and things like that out in the community for longer. And so I presented that to the Health Select Committee because I really, really passionately believe that we are doing nothing towards the nutrition of the population, and we're just storing up problems that are going to be solved or not solved 30 years down the track by much more expensive interventions.
100%. And if you look at any mental health blueprints, any government organisational, support for mental health, nobody mentions nutrients or the food we eat.
Up in the top of the South Island, I have a young colleague who was on a temporary contract, was looking at the early psychosis kids, the youngsters who have had first episode of psychosis, or women who've had postpartum psychosis, and was involved in nutritional interventions for them. This hasn't been funded. She is now back looking for work.
Yeah, I mean, if you think about how much money this would save the future generations of New Zealand if we're looking at nutrition for all aspects of health, obesity, cardiovascular disease, mental health, suicide rates, all, everything.
And the thing is that when, as a dietitian, where I see us fitting in is we're never going to be enough of us. We're down to 2 training schools again. We were at the peak of it, 3 training schools, maximum number through 90 a year. We're down to 2 training schools, both in Auckland. We will be there for supporting our registered nutritionist colleagues, our health coach colleagues, all of that kind of thing, and doing the complex stuff. And so, for example, we are prescribers, very limited scope. I look enviously across at nurse prescribers and go, oh, that would be so much better. But that would be something that would remain in dietetic scope, and that's okay. The prescribing of specialist products. We have great conversations about how you make sure that you meet special authority criteria for some of the specialist nutrition products. That is absolutely within our scope. But, we also need to be supporting, so say, for example, the Japanese model. The Japanese schools have dietitians managing the food services. So they are designing the food for their people. Now, don't need a dietitian doing that. You need people with strong food service skills who have support from a dietitian.
Yeah, I think this is more and more the case. There's a lot more health coaches coming out, and everyone I've spoken to has just said, if we can get health coaches, because for the average person, not specialist, not a specific disease, but for the average person, support around nutrition is often things like going grocery shopping, supporting how to cook. We don't need a dietitian to design a specific food plan necessarily. It's really bringing it down to the basics.
It is. And the thing is that where dietetic skills comes in is when you've got the complex conditions, when you've got someone whose diabetes is so out of control that you're thinking, hang on, are they doing all of the things right? Do we need to be modifying their diet? Do we need to do a diabetes reversal program to try and at least get that HbA1c down and some of the visceral fat out of their poor old pancreas? Yeah. And the thing is it's actually a call to arms for my dietetic colleagues. We can't work at mid-scope. We've got to work at top of scope. And that can be tiring.
Yeah, I see what you're saying. And I think in many cases, if you could think of every GP surgery having a health coach that's specialised in diets or nutrition, or
well, in fact, I want them to be dietetic assistants. Actually specifically focusing on nutrition with a qualification, probably NCA 5. So we're talking, that first 2 years post, not necessarily a degree, though we get a lot of people with applied nutrition degrees coming into health coaching. I often say to people, and I say this to my dietetic colleagues a lot of the time, a little knowledge is a dangerous thing. So when you know a little bit about nutrition, you will make some very broad brush strokes, and that will not be right for every individual. You actually need to skill these people up that they get a little bit freaked out that when that person with their CKD3, who is actually just about due to go through to the renal clinic, the kidney clinic, to be discussing whether they're going to go on dialysis, they should be freaked out about that person. And when the doctor says, oh, we want you to give them dietary advice, they should be going, hell no. I can give them some support around how are they feeling about going off to that clinic, and, have they got things in place that they are actually going to get the support they need for that clinic, but not giving the advice. I won't touch renal disease unless I know they're in their stage 5 and not going on to dialysis.
Yeah. So that is about knowing your scope in an appropriate way, or knowing your limits, or knowing your boundaries, and knowing when to refer. And
knowing also that you can say no to someone who is senior to you, and you're not going to get your head ripped off. And I joke about the number of times that I have had very grumpy doctors. Fine, I don't have a problem with that. I happen to have a godfather who was a surgeon who was an absolute bastard. He taught me actually that they're all bark and no bite. And the net result was the training meant that there's been times that I know that I've gone up against people who could really make my life difficult. And only one of them has ever done that. And that's a whole story in itself.
So not only as a dietitian, we're advocating for the patient, but we are also in some ways advocating for other health professionals that may or may not be dietitians, but actually supporting them in a role within their scope to do a job, because there's not going to be enough of you.
And the thing is that takes a lot of courage, because you've got to be really good at what you do yourself. And I'm now working through a process of trying to find some funds to put together that kind of education for other professionals. Lots of people are working in the space of client work, and I might eventually end up in that space. My space is for working with other professionals.
So, Helen, what do you think needs to change? What barriers need to be broken in order for a whole person approach to be a more standardized form of treatment in dietetics? And I'm sorry, that's a very big question.
Oh, that's a loaded question, isn't it? In the UK now, as well as the traditional way of going through dietetics, undergraduate nutrition, postgraduate dietetics, they've now got this thing called dietetic apprenticeship. They've actually got a number of apprenticeship schemes in the NHS. So you would come in with sort of the equivalent of university entrance. You would be working as an assistant in the hospital for 3 days a week, 2 days released to education. Within 4 years, you will be qualified as a dietitian.
Right.
They are not going to be this high scope that we need, but that's when people can then go on to master's qualifications if they wish. And the thing is I joke that I'm one of the last of the PG dippies. So postgraduate diploma in dietetics, don't have my master's qualification. But the thing is that we've got to have something similar. We've got to have other ways of bringing diversity into the profession. Yeah, we're seeing some ethnic diversity. We're seeing some gender diversity. We are not seeing the level of cultural norm, but also economic norm. There is a lot of privilege still within the profession. And the thing is that privilege, and I recognise my privilege very much. I grew up in a very privileged family. I come from multi-generations of educated women. That's a lot of privilege to carry, but it's given me also the space, because my parents also recognise their privilege, to actually understand that to have privilege is to serve. So you serve people because you are given extra things. And so going into the community and serving. If I could do dietetics as I wanted in the public system, I would still be in the public system, but couldn't do it that way.
So when you say you couldn't do it that way, in this sort of more holistic manner, or?
It was holistic. It was actually things like, so again, my UK experiences, we did models like having dietetic assistants. We had dietetic assistant practitioners who were slightly more advanced in their skills, could hold a caseload independent of the dietitian, but it had to be within a particular clinical area. That is the kind of work we need to be doing, and giving health coaches a progression as well. I know in nursing, for a while, enrolled nursing virtually became an extinct field. It's now come back, and it's given a career progression that I've seen happening from junior caregiver, senior caregiver, enrolled nurse. And I've actually just recently met an enrolled to registered nurse jump, which I was so excited about.
So it's actually giving people that space to develop in perhaps an area that they want to, or a specialist area that they want to as well. Yeah.
And I mean, when I am doing my challenging talking to my colleagues about this stuff, I say, look, for some of us old fossils, we are going to have to think about masters by applied practice, doing the capable program through the polytechs, where they look at the things that you've done, and hopefully you've done enough to earn a master's degree out of it. I'm kind of terrified of even starting that process. Just, I know that it would be okay, but I'll probably find that I have to write something, and it's like...
So two other things that we sort of thought we would chat about on the podcast. One was the Te Whare Tapu Whā model. Is this something that you bring into your practice as well?
I always say I even managed to translate into NHS.
Right, wow.
Which was interesting given that there was, at the time that I was there, people being disciplined for things like praying with their patients and things like that. So mentioning the word spiritual was, shall we put it delicately, challenging.
Wow.
And so I always talked about how we relate outwards from ourselves to the community as being that community relationship, and how the community relates inwards to us in place of the spiritual. Because in fact, what fundamentally spirituality is actually about community. If we, why do people go to churches? Well, why do they also go to bowls clubs, to whatever? It is to find a space where they are part of a community. And managed to navigate without getting fired over that one, so that was good. But I really see that we've got to look at the individual, we've got to look at the family, their community, and how the community relates to them and where they fit. I work with a Maori ACC provider, and one of the people in there, he also adds in the whenua, the land. So the fifth element of Te Whare Tapu Whā being the land. And for me, that represents not only the roots of our history, but it is also the conservatorship of land. It is making sure that when we are farming, and we can't get away from the fact that we will have to farm to feed our people, that we are doing stewardship, not basically just washing superphosphate down the drain. And my sister's actually a soil nutritionist. She is fascinating to talk to. And again, telling a funny little story, last Christmas we were picking up strawberries from a strawberry farm, and just as we were walking out, she was looking at the strawberries and she was muttering, I told them they needed to put potassium on the strawberries. And I said, so what's the problem with no potassium on the strawberries? She said, they're not going to be very sweet. Damn it, she was right.
But yeah, I think because a lot of times the environmental part gets missed out when we think about these 4 pillars. And I'm like, hang on a minute, there's the 5th pillar. There's our land, there's our environment, but it's our land. And the quality of the food that we're growing also. And the nutritional deficits that may be occurring due to soil or even due to what's happened naturally, because I understand that New Zealand soils are a little bit deficient in selenium and boron. And
well, in fact, New Zealand soils are just horribly, horribly deficient naturally. And the 2 little interesting stories I can tell about that is I had a young fella turn up with some really peculiar symptoms. And I call these my interesting cases. And I was thinking, there's something I'm missing here. And I actually got very interrogative about his food supply. Now, he was eating 90 to 95% wild meat. And I went, hang on, what's going to be the deficit here? Selenium and zinc.
Yeah.
Got the tests done after twisting the doctor's arm. He was deficient in both. Supplemented back, said, look, you need to once a week have farmed meat or be on a supplement. He's a box of birds now.
Yeah, it's interesting, isn't it?
And I mean, when I'm working with rural people, which I do have a big outreach into the rural Southland and Otago, often we do get talking about nutrients, and particularly the older men tell me all kinds of stories about seeing the direct impact of not enough selenium, of not enough cobalt, and that kind of thing. And, they were often very profoundly affected by seeing the loss of all of the lambs through spontaneous abortion at non-viable stage because of the lack of selenium.
Yeah, and it's interesting, isn't it? Because they supplement the animals on the land.
Yeah.
But we don't supplement the humans.
Yeah, and the thing is here's a really useless dietetic fact, but also useful. The Brazil nuts that are grown in Brazil are high in selenium. The Brazil nuts grown out of Brazil are not high in selenium. Do you know where your Brazil nuts have been grown? Most of us don't.
Most of them are grown in China, actually.
Not a reliable source, because China also has depleted selenium.
Exactly. Yeah. So I did a little experiment with myself, and I started to eat a few Brazil nuts every day. I didn't do a before test, but I did do an after test, and my selenium was actually really high, so I actually stopped eating the Brazil nuts. I don't know where those Brazil nuts were from actually, but clearly they had some selenium in them because my levels were.
So, I mean, the dose of selenium, if you have got selenium-rich Brazil nuts, is 2 nuts a day.
2 a
It's
day,
not a
yeah.
lot.
No,
Yeah.
it's not at all, and it's actually I encourage people to do that. I say, look, if you don't want to supplement, take a couple of Brazil nuts a day. That's gonna meet your needs.
And I mean, the other interesting thing on the prescribing front, we don't have a complete set of prescribable nutrients on in the NZ formulary, and many of the things we do is what I could politely say the dirty versions. So zinc, the only one we've got available on prescription is zinc sulfate. Now if that doesn't give you the skitters, nothing's going to give you the skitters.
It's a bit bizarre, isn't it? We have the capacity, the capability of actually developing a wonderful micronutrient formula, New Zealand made, that would probably fill a lot of gaps for a lot of people, and yet it's not funded. We don't have it.
And in addition to that, is we are regulated by very old legislation around what can and cannot be in our supplements. It's mid-80s stuff, the transformation, particularly in the trace nutrient side, and we won't even mention microbiome since that time, has just been huge. And yet we've had the ADHD supplementation basically ground to the halt because someone decided to apply that that set of criteria. Bariatric supplements, same thing happened. It's actually quite a significant problem, and I don't see there being much legislative appetite to change that, because again, I think coming back to often when we talk about people seeing such things as weight loss surgery as an easy way out, they also see having supplements as an easy way out, not realising that actually not everyone can get adequate nutrition from food alone.
Absolutely, for all sorts of reasons, apart from even eating it, but even genetics, there are some people that need more.
I mean, I've got a dear friend who just sent me a message going, my iron's tanked again. And because I've just done a bit of a rabbit hole down iron absorption, because I can prescribe iron, I said to her, look, go to the every second day to see whether it's actually you're not picking up iron enzyme, which is actually over-regulating with the daily iron. Be very interested to see what happens.
Yeah. I can see that.
We could talk for hours.
We could talk for hours, couldn't we? Because there's so many little rabbit holes to go down.
I mean, one of the questions that you put in here that I'd like to answer is actually, what would you say to someone who discovers they need to see a dietitian for whatever lifestyle change? What would be a bit of advice? And I'd say take a big breath and then take about 10 more and then go, we have time on our side to make changes. We do not have to make all changes at once. And in fact, the fastest route to failure is to have to make multiple changes at once. Prof Mann, who used to do the diabetes here, he's still floating around as an emeritus professor. One of the lessons he taught us was if someone has got really shocky cholesterol, they've got at least 3 months in which we can do a dietary intervention before we need to start the drugs.
Right.
And so the thing that I want to say to people is often, particularly when you're relying on internet-based stuff and things like that, you have this, I have to do this much. And that's like eating an elephant. It's really hard to do. But actually, we've got to start one step at a time. And what moving you towards a better diet would look like might be quite different to what I need to do. And because we have this incredible negative narrative that often goes in our heads, if we have struggled with things, we actually have to understand that compassion is one of the first bits of it. And I am very blunt with people at times when they're telling themselves off. I go, hang on, can we just check in here? So when a baby's learning to walk, would you beat it for falling over? And they sort of look at me horrified. And I go, so why are you beating yourself up for not getting a new skill first time?
Yeah. Gosh, that's very powerful, isn't it, to think of it that way. When you're trying to change a new habit or trying to bring in a new habit or break an old habit, that's a way to look at it.
And, it's no wonder I get tears in that.
Yeah.
setting.
Totally.
And, you know, the other thing I really wish that is that when there is issues of body weight with one child in a family, the role of the parents is not to police the diet, as in to say, you can't have this, you can't have that. It is to offer an appropriate diet for everyone in the family and to create a supportive environment that that child feels loved, nurtured and supported. So there is not secretive eating. There is not, all of the guilt associated with it. I once said to a social worker, because I was involved in a family concern situation in the UK, I said, your way of threatening that they have to see the dietitian slams the door shut for the parents and for the next generation. How dare you use me as a threat because they are bad parents?
Oh, yeah. This is that whole thing about a completely different approach to actually partnership in care, empowerment, and actually supporting a person, meeting them where they're at.
And the thing is that, so for example, within the trauma space, of course, we've got lots of undiagnosed neurodiverse people. That is a really interesting space. I have people who come and say, I was force-fed vegetables because my parents got pissed off with the fact that I wouldn't eat them. And I go, it's the texture, isn't it? And they'll usually go, yeah. And some of them will still be at the stage they won't eat vegetables. And I will go, so is this every vegetable under the planet? And they might go, oh, no, I can have raw carrots and frozen peas. And I go, fantastic. We've got one green, one orange. You now, if you do 325 grams of that a day, I'm going to give you a get out of jail free card that you don't have to eat any other vegetables. Actually, that gives permission that they can safely try them in their own time.
Yeah. I can see that that's meeting them where they're at completely, walking alongside the journey with them, all those wonderful things that you can.
And one of the lovely stories is one young fellow who did definitely start it. He was in my mind when I said frozen peas and carrots. We worked on and off for 2 years, and he never fully disclosed just how tough it had been, but there were little hints of just how tough the family context had been around food forcing. And anyway, so he developed quite an interest in things, and he developed some cooking skills and all of this kind of thing. Last time we got together, I said, tell me some news. And he said, ate a vegan meal. And I went, holy camoli, and did this dramatic fall off the chair and things like that. And I said,
oh, how
do you
wonderful.
think we might be finished working together? And he said, yeah, no, I thought that might be the case.
That's amazing. It's a slow journey, isn't it?
But the thing is he had the time. But even someone who has got a shocking diet and perhaps has a diagnosis of prediabetes, we've got the time. It doesn't have to be a sprint.
Yeah. Fantastic. Thank you so much. Are there any last words? Is there anything else that you want to say to either clinicians listening or to people that might struggle?
To clinicians listening, one of the tips I give all my young practitioners is when a person turns up and sits down in front of you, you say, what made you decide to come and see me today? Not how can I help you, not what's your problem. What made you decide to see me today? It actually shortcuts a whole lot of rubbish. And it can sometimes actually bring out the real problem as the priority. And when I say this to new graduate dietitians who are going into practice, I say, yeah, of course you're going to get the referral. Of course you're going to get the bloods. Ask the person. And almost every single one of them comes back to me and goes, oh my God, that's just shortened 20 minutes of mucking around out of my session. That being open does not have to prolong sessions. Actually, some of it brings us into shorter communication, much clearer communication. And the other thing is don't be afraid to explore the feelings. One of the stories, and it's a bit of a joke against me and it's a bit of a joke against a whole lot of things, was I had this very, very broad Scottish speaking woman. She was from the northeast, which if anyone has ever been to the Aberdeenshire area, they speak another language. They don't speak English. It's a thing called Doric. Anyway, she was furious as she came in from she'd seen the registrar. Okay, right, have to deal with the feelings first. Hey, Mrs., how can I help you? Again, you're not doing very well here. You're feeling pretty upset. Oh, that's Sassenach, doctor. I was thinking, Culloden 2 is about to happen. He called me a beast. Obese. In English, translated to a beast. In this Doric speaker's head. And I went, I'm so sorry that happened. It was a miscommunication. This is the word we use for your extra weight. Oh, why didn't he just say that?
Oh my goodness. Yeah. Oh, fantastic.
But the thing was, she was right as rain because I actually asked the feelings.
Yeah. And I imagine that so many of the people that turn up in your clinic, it's feeling. I mean, yes, they get the referral, but it's feelings.
That's verified. Look, us dietitians have such a interesting reputation.
Yeah. And you're going to take all the food that they like away. That's what I would. I mean, if I was told to go and no, they're just going to stop me from eating chocolate and salt and vinegar flavoured chips.
So the funny thing is that I often say, so chocolate's a food that you find hard to manage, yeah? And they'll go, oh yeah, can't control myself. And I go, so the funny thing is that's actually your inner child going, you don't let me play very often, so I'm going to let loose. And I go, so what would it be like to give that child the space to smell and to feel and to touch and to sense? But that means taking the TV off. That means not having your phone in front of you. That means sitting down and respecting that food. And most people look at me like my head's dropped off at that point.
Mindful eating.
Mm-hmm. Yeah. And the funny thing is one of my ladies once sent a text to me, said, I have a bone to pick. I've discovered I actually don't like chocolate because of the way you did it.
Yeah, it's amazing, isn't it? When you really stop, am I really hungry? Am I really enjoying this food? Do I really like the taste? Do I really like the texture?
And I mean, the funny thing is I think her message was chocolate is a food that women use when they're distressed, that she learnt from her mother, rather than actually recognising that this was something that didn't work with her.
So it wasn't even her story. It was her mother's story that she sort of inherited and took over.
Yeah.
Fascinating. So Helen, if somebody wants to come and see you, is that something that they can do? Where can they find you?
So we'll find me online at dietconsulting.nz. I have a little bit of a waiting list at the moment, which of course is a privilege, but it's also like, oh my goodness. And the thing is I don't sell packages of care. I don't believe fundamentally do not believe in packages of care. We need to be guided by that individual's need as to how much care they need. And that's actually a really important part of my ethos. And self-referral's okay, but one of the things I always say is I want to be working in partnership with your GP if you're under specialists.
Yeah, fantastic. Thank you so much for your time today.
You're welcome, and it was lovely to talk about it.
Yeah, for the work that you are doing. And it's opened my eyes as well as to what a dietitian actually does. Yeah, because I've only really worked with them in the hospital, so I've only seen them on that side of the healthcare system. So it's really lovely to hear what you do.
Yeah, ka kite anō.
Okay, ka kite.
Bye.
Bye bye.